Good afternoon, everybody. Welcome to our ESC Daily Highlights, live from Barcelona. I'm very, very happy, very delighted, and very honored by the participation of Professor Carlos Aguiar, who accepted our invitation. Thank you for accepting our invitation. Professor Carlos Aguiar is a cardiologist in Portugal Hospital. His field of interest is heart failure, but also cardiovascular prevention, and he's a member of the board of the European Society of Cardiology, and he shares the communication of the European Society of Cardiology. Yesterday, I was very delighted to attend the big debate about aspirin and does it have a remaining role in the prevention of cardiovascular disease, primary and secondary prevention. So, what do you think, Professor Carlos?
Well, this is a great opportunity. I'm delighted for the honor of having me here to speak about this. And you know, aspirin is now 125 years old, and an extra couple of weeks. The celebration of the anniversary was on the August 10th. It's been a wonderful drug. It's been first in class for 2 times. It's the first non-steroidal anti-inflammatory drug we have. So it was very important for many decades, and it still is in the treatment of pain and arthritis. It's also been the first in class for the antiplatelet agents, and that was a very important thing at that time when we didn't have statins, we didn't have good medications for lowering the blood pressure. Aspirin certainly saved many lives. But you know, cardiovascular medicine has really evolved so much. There are so many new developments. Patients are also different. They're living longer, they have more comorbidities, they have more issues, and there are concerns nowadays that maybe aspirin's role in the prevention of cardiovascular disease is not the same as it was some years ago. And this is particularly a significant discussion when it comes to primary prevention of cardiovascular disease, where the risk-benefit balance is not so positive, it's only slightly positive. It nowadays looks like aspirin in this era of good medicines for hypertension, good medicines for diabetes, and good medicines for lipid lowering, it looks like aspirin in primary prevention can still help reduce the risk of ischemic strokes, but not of the more severe ones, the ones that cause disability or that cause mortality. So this is a small effect that may not have such a big difference in the person of a life, in the life of a person, especially if the bleeding risk of that person might be too high. But we are becoming better at improving our capacity to predict if cardiovascular disease is going to occur, if a patient is going to have a stroke or a myocardial infarction. We also need to get better at improving our prediction of bleeding. And I think with some of these improvements, in the near future, we might be able to really select better in primary prevention who are the patients that will benefit. But for the moment, a routine use of aspirin in primary prevention is not recommended in the guidelines. Now in secondary prevention, this is a completely different story. It has been challenged though, and my opponent yesterday challenged the role of aspirin in secondary prevention by arguing that the trials are very old. Indeed, some of these trials are quite old, but importantly, the trials show that compared to doing no antithrombotic therapy in secondary prevention, giving aspirin to our patients not only prevents non-fatal events, it prevents mortality, overall mortality and cardiovascular mortality. So it's really impossible to discard this evidence and say, no, we need to do everything again, when it's as strong as saying to us that it reduces mortality and disability in our patients. Now, aspirin has been challenged by other antiplatelet agents in secondary prevention, namely the P2Y12 inhibitors. These are clearly, in pharmacodynamic studies, they're more potent antiplatelet agents, and so they have been tested against aspirin in several trials. And some of these trials are actually very recent studies. They were published last year, so we've got very good evidence on this comparison. And P2Y12 inhibitors are not really that much better than aspirin monotherapy. They do lower somewhat the risk of non-fatal myocardial infarction, but that's it. And it looks like that's mainly in patients who have symptomatic lower extremity arterial disease. Otherwise, there is really no significant benefit. Plus, they are more expensive than aspirin. So, even if you wanted to say, no, now we should be doing P2Y12 inhibitors instead of aspirin for long-term secondary prevention, you really need to do the cost-effectiveness analyses in each geographical setting to be sure that this is going to be something worthwhile and with value. A more recent challenge to aspirin in secondary prevention is the combination of aspirin with something else, either a P2Y12 inhibitor or a factor Xa inhibitor. But this obviously for very selected patients who do not have a high bleeding risk and have a very high ischemic risk. These different patients are not very easy to find, but they may derive some benefits compared to being on aspirin monotherapy. Although most of these benefits are on non-fatal events, not on the more severe events, but again, if we manage to find ways in a personalized medicine or precision medicine approach to really find those patients that may derive benefit from being on more intensive antithrombotic therapy, then that will be possibly a good thing to do. So my main take-home message is that for the moment, in primary prevention, routine use, no. In secondary prevention, there still is nothing better than aspirin monotherapy, and we need to move the field forward by looking into strategies of more tailored therapy for our patients based on their individual risk-benefit profile.
Yeah, we talk about individualization therapy, even in primary prevention, but also in the secondary prevention. I think that we haven't enough now clinical trials to stop aspirin many days after, the very, very long term, 10 years after or 15 years after.
Absolutely true. There is no clinical trial that has tested stopping all or any antithrombotic therapy. We do have, well, it's not randomized data, it's only observational data, so there are limitations to using observational data that all of us are aware of, but there are several studies using observational data showing that in real world, stopping aspirin and staying on no antithrombotic therapies is very harmful. There is a very short term, a very immediate risk of an increase in cardiovascular events, and it doesn't fade away with time, so it only gets worse. The only patients where there may possibly be less of a risk are very elderly patients that still remain on other treatments. So it's something that I would certainly say people should not be doing. We should not be stopping antithrombotic therapy after an acute myocardial infarction, an acute ischemic stroke, certainly not. After staging, very dangerous.
Thank you very much, Professor
Thank
Carlos,
you for the opportunity.
And hope see you
and my
in
greetings
Tunisia.
to the Tunisian Cardiovascular Society. Thank you so much.
It will be a great pleasure to have you in Tunisia. Thank you.